Thank you for the invitation to come and speak to you folks. After that last session, I feel very inadequate and humbled by the lack of our knowledge about what happens to these children. I was asked to talk about medical conditions of particular risk for patients with SLOS. Particular risk. What is the risk? Risk is the possibility of something bad happening. We all know that. And we all live with risk every day. Some of us, the risk is more close to us and close to those around us. And some of us try to ignore the risk, and others try to deal with it as best as they can. And I think that what we know about risk, medical risk, particularly in SLOS, is greatly missing. What are we dealing with here? Risks for complications of the disease are really poorly understood. What we know about the risks, the particular risks for kids with SLOS, are based on the slightest information, really. Anecdotal reports in the literature, the limited number of rare patients like having SLOS, personal experience of all of our physicians. My experience as a physician in this disease is not the same as Dr. Elias or Dr. Porter or any of our physicians that we deal with on a regular basis at home. Some of our physicians don't know very much about SLOS, and we have to work with them because they're the ones taking care of our kids. Sometimes our risks are what we know about risks are based on hearsay, what other people have told us happened. But everyone's risk is not the same. Some people are at higher risk than others. We all know that. The probability of medical complications that are risky in this disease are probably related certainly to the mutation that causes the disease in part. Certainly the severity of the cholesterol deficiency with more risk probably associated with lower cholesterol levels, and that may be related to the mutation that causes the disease. It may be related to other things, however. We think that our risk is probably associated with random factors that we have no choice and no control over. It's like throwing a set of dice and just wondering, are we going to come up with snake eyes or sevens, We know that the risk of all genetic diseases is based also on other genes that we carry. That's why the risk sometimes for complications is different in one sibling compared to another. Both of them may have the same genetic defect, but they have different genes, the background genes that we all deal with. We don't even know what these genes are that increase the risk. We know that there's risk associated with environmental factors. So we have SLOS, and we have environmental factors that influence that disease. Every genetic disease is impacted by environmental factors. Things that we might not have control over, things that we do have control over, and things that we don't even know are adding to the risk for complications. The risks associated with complications in this disease, like in all others, are also independent of other medical complications, or sometimes they're related to other medical complications. And the risks change over time. Some of the most severe children with SLOS don't survive beyond a few weeks of life. Others go on for a long time. And sometimes patients will ask me, how long will my child live with this disease? What does the future hold? And I can only say that after almost 40 years of practice, I cannot predict what the future holds for any particular child. And those are risks that we have to deal with. But they're things that are yet to be learned. We don't have enough information really about this disease. We desperately need more research. We need to know more about more patients. This is a rare disease, so we have so little information about these kinds of patients. We just don't have enough information about them. We don't have enough patients, first of all, to give us that information. And with rare diseases like this, we really suffer a lot by not knowing things. So if you look at the likelihood of a risk, I show here on the right, this is a normal distribution. If we consider all of our SLS kids here with risks, some of the kids are going to have a low, or let's say a less likely risk for a complication, like we just heard about. In other kids, the risk will be higher because the majority of kids will fall into that higher risk. We just don't know at this point in time whether a particular risk that I'm going to discuss occurs frequently, occurs infrequently, or rarely. We hear about the worst cases, not only as far as complications of a disease like this, but also the incidence of the disease. And I can assure you there are people walking around with mutations in this gene that have a very mild form of SLOS that has never been diagnosed. So we don't know if any particular problem is at a high risk for us or a low risk. With that background, I'm going to throw out a few options here, and I'm going to tell you that what I consider high risk or moderate risk or lower risks are my ideas. They're not always based on fact because we don't have the facts. So I'm going to discuss some of these risks today. But just realize that I'm really speaking in a great deal of ignorance at this point. I wish I could be more definitive. I just don't know. Adrenal insufficiency, I think, is a high risk complication of SLOS. And when I say high risk, I don't know if we're talking about 10% of the population, 20% of the population, or 2% of the population. I think it's more than 2%, but I just don't know what that risk truly is. It's not defined. What is adrenal insufficiency? Some of you may never have heard this term before, but it's the adrenal glands and the function of the adrenal glands that's impaired under these conditions. So the adrenal glands are located on the top of the kidneys, as you can see in this diagram down below there, the yellow area there. The adrenal glands make something called cortisol, okay? And they make it based on the command of things going on in the brain. So the brain has an area called the hypothalamus, which makes a hormone, CRF, which stimulates another hormone called ACTH to be secreted, and the ACTH goes to the adrenal gland and stimulates the production of cortisol. Cortisol is made from cholesterol. There's the tie-in with SLOS. If someone has very low cortisol levels, there's a high likelihood that they have if they have very low cholesterol levels, there's a high likelihood they have very low cortisol levels. And what does cortisol do? It's so important to the body. First of all, it increases the sodium in the blood, and it increases the blood pressure. So that's one effect of cortisol. Another one is that it increases your blood glucose level, the sugar in the blood. And a third very important function of cortisol is to fight stress, okay? So if you have low cortisol levels, like some SLOS patients do, you find that they may present with low blood pressure, giving a lightheaded feeling. Maybe you have a headache, or they could even faint under those conditions. Oftentimes, their sodium levels are low in the blood, and that can lead to vomiting or irritability, headache, even seizures under the severe conditions. Cortisol is necessary to keep our blood glucose high. So under fasting conditions particularly, as when a child gets ill and stops eating, that leads to low blood sugar. And that can cause fatigue, of course, early on, sweating, confusion. And then finally, cortisol is important in fighting stress. So what are we talking about? So stress is associated with fever. Our bodies are under stress when we have a fever, right? If we develop a serious infection, that's a big stress to the body. And if you undergo surgery or anesthesia, that's a big stress to the body. So all of these are fought by cortisol, okay? And if the cortisol level is low in any particular child at any particular time, they have a hard time not only managing their blood glucose, their blood pressure, their sodium levels, but also fighting stress, being able to combat those particular infections. Sometimes we can get a feel for whether someone has a low cortisol level if they have elevated pigmentation to their skin, okay? What happens is the brain perceives a low cortisol level. In an attempt to make a higher cortisol level, it produces more ACTH, which goes to the adrenal gland and stimulates cortisol production under normal circumstances. But if you don't make cortisol because your cholesterol level is so low, as in SLOS, the brain perceives we need more cortisol, right? So it puts out more ACTH. And ACTH is a molecule which is metabolized and causes increased pigmentation in the skin if it's over a prolonged period of time. It doesn't happen in a day, in a week, or maybe even in a month, but it occurs eventually in someone with chronic low cortisol levels under these conditions. And it certainly could be a possibility that some of our SLOS kids have low cortisol because their cholesterol is so low. It's not good to run low cortisol levels, especially because of all these possible complications that can happen. How do we diagnose adrenal insufficiency? Well, it's a very easy test. You get a blood sample and you measure cortisol at 8 a.m. in the morning, and you also measure ACTH levels. So why do we do it at 8 a.m. in the morning? Well, it turns out that the levels of cortisol vary throughout the day. It has a diurnal variation, which you can see here on the right. Early in the morning, it tends to be its highest. And if you're impaired in the production of cortisol, that's when you want to look for it, because it should be produced in high levels at that time during the day. So if you find a low cortisol level in a patient, whatever the cause, if it's SLOS or if it's some other disease, and you find high ACTH levels in the patient, you know that they have adrenal insufficiency or adrenal failure. And we can treat that very nicely and equally, efficiently, I should say, by giving them hydrocortisone, just as a tablet or as a liquid. Sometimes we have to add another hormone that's made from cortisol, and we give them a drug called fludrocortisone. And this helps absorb more sodium and increase the sodium in the blood a little bit better than hydrocortisone by itself. If you know you're dealing with adrenal insufficiency in someone, you have to cover them for stress, and you give them extra hydrocortisone under those times because they need it under those times. So whenever they have fevers, serious infection, or undergo surgery and anesthesia, we give them stress doses of cortisol. Adrenal insufficiency. What is the likelihood that a child with SLOS will develop adrenal insufficiency? I can't tell you. I don't know. Electrolyte disturbances have been reported in patients with SLOS, and there are complications from that, and some of these can be illustrated here. First of all, low sodium, as I mentioned before, right? It's called hyponatremia in medical jargon, and it can cause nausea and vomiting and irritability, confusion, as I mentioned here, headache, muscle cramps, muscle weakness by itself, seizures. If it gets super bad, you can even cause coma in a child. Hypocalcemia is a low blood calcium level. Calcium levels, if they drop, in the blood significantly will cause symptoms of tingling in the hands and feet, sometimes even in the lips, numbness at some times. Muscle cramps in the hands and feet especially are seen in younger children, something called tetany, or the cramping of the muscle. And in kids, you tend to see the thumbs being pulled in like this, okay? And you try to move them. They can be moved out, but they go back in because the muscle is cramping in the hands, the small muscles of the body. Sometimes facial twitching is a part of hypocalcemia, low calcium. And even low calcium levels can cause a change in the heartbeat, maybe the slowing of the heartbeat. So whenever you see something, if you see your child have these kinds of hand cramps, get them to the doctor, have that measured, because it's easy enough to diagnose. You just require a blood test. You take a blood test, you measure the electrolytes in the blood, the sodium, potassium, chloride, etc., including calcium. And always, if you find low calcium and low sodium particularly, check for adrenal insufficiency. That should be done on a regular basis, I believe, in kids with Smith-Lemli-Opitz syndrome. It's easy enough to treat hyponatremia or hypocalcemia. You can give it orally, you can give it intravenously. It really can be treated quite effectively. If the calcium level is low, we give calcium supplements. Some of you may be taking calcium supplements yourself because oftentimes women take calcium supplements to prevent osteoporosis. We add vitamin D with the calcium oftentimes, not always, but most of the time, if we have someone with a low calcium level. And that's because vitamin D improves the absorption of calcium from the diet. So it helps the dietary calcium get into the bloodstream and into the body. So easy treatment, easy diagnosis for this case. I'm going to say a few words about immune dysfunction and infections. And we've heard these stories just now about kids who've had what sounds like infections of some type. And I think that is a high-risk complication of SLOS. And I just don't know to what degree it is a risk. I don't know if we're talking about high, medium, low. I just don't know. I don't think there's any data out there. We do know some publications have come out, anecdotal publications, single cases or a few cases only. In one case, antibody levels were low in a patient with SLOS who had recurrent respiratory infections. The patient also didn't show a normal immune response to immunizations, in this case Pneumovax, which is a pneumonia type of immunization, and hepatitis B vaccine. So something is going on. Whenever we immunize someone, they should have a nice immune reaction to that antigen that's given in the immunization, and they should be developing antibodies and an immune response to that. And in this particular case, the child didn't have that. In another case, there's a report of a fatal adenovirus infection. Adenovirus is a respiratory virus that causes pneumonia, and this child had that kind of infection. Recurrent or fatal infections have also been reported in 3 of 14 SLOS children who died of sepsis. Bacteria in the bloodstream, sepsis, very serious, oftentimes fatal infection. And then 2 other patients with SLOS in this particular report had recurrent infections. And they also looked at fetus, the anatomy of the fetus of 2 children who died in utero, and they found that the thymus, the part of a gland here around the neck, was not developed properly. And that gland, the thymus, is important for developing a strong immune system in our body. So there may be something going on with immune dysfunction, with a propensity for infections simply because of that. We don't know a lot about that. I'd like to say a few words about respiratory infections because these are among the most common infections that affect all of us. We can kind of divide, as a physician, we kind of divide it up between lower respiratory tract, upper respiratory tract. So lower respiratory tract infection is what we call pneumonia, causes infection of the lungs with cough, Fever, rapid breathing is a particular sign of that. Chest pain sometimes, lethargy, pallor or paleness to the appearance of the child. These kids really look sick. These are not kids who are just fussy, but they really look sick when that infection proceeds to involve the lungs. They typically don't eat well. The infection can progress very rapidly, and a variety of other symptoms may be seen as well. And these kinds of infections, respiratory infections, are typically caused by bacteria or by viruses, okay? The viruses, there's a whole variety of viruses, there's a whole variety of bacteria can cause pneumonia in children. Viruses include influenza. I want to emphasize that. But it includes a lot of other viruses, too, that can affect not only the lungs, but the rest of the body. Viruses may infect the heart, the muscles, other organs as well. So bacterial sepsis, okay, is a situation where you have bacteria that have gotten into the bloodstream and are now growing and going all over the body. It leads to a humongous stress to the body, and that is a life-threatening situation. In contrast, upper respiratory infections are things that we all suffer every year. These are colds, runny nose, soft cough, sore throat, low-grade fever. Sometimes we'll have other associated infections or symptoms associated with it, I should say, like diarrhea or a rash. Usually these are caused by viruses. Most of the time, these are benign diseases that run their course. They're not something that we typically treat with antibiotics, and we usually get over them. But some viruses move on very quickly and can progress and cause serious and even life-threatening disease. I'm reminded of the great influenza pandemic that occurred in 1918, in which people in this country were healthy at one point, they got the virus, and 8 hours later they died. That fast, these kinds of infections can proceed. And that means that we have to be very vigilant about that with our children. Just a little diagram here. Pneumonia, you can see a blow-up of the lungs there. The normal air sacs are open. These are called alveoli. The air that we breathe in gets into these sacs. They expand the sacs. We absorb the oxygen. But if you have pneumonia, those air sacs are actually filled with mucus and fluid and so on, and they don't open anymore. So we are in a situation there where we can't get the oxygen that we need. We have to breathe faster in order to get that. And so what happens is a lot of times kids are very sick, as I mentioned before. They have what we call tachypnea. They're breathing very fast, and that's a sign of a serious pneumonia. How do we diagnose and treat pneumonia? Well, it's not that difficult. Physical exam, we get vital signs. We want to know the respiratory rate. Children, even adults, will oftentimes be breathing faster than usual. Our heart rate will be increased because it's a stress to our body. Oftentimes with fever, our heart rate is increased from that alone. We look at the blood pressure. We want to make sure the child's blood pressure is not too low. We listen to the heart. A physician that puts the stethoscope on your chest will listen as you breathe in, and they can hear sometimes those air sacs opening up as you breathe in. Sometimes you can even perceive it yourself. I don't know if you ever noticed this, but you can sometimes hear the crackles that go on as you take a deep breath, for example. We look for sometimes in parts of the lung when we're listening with the stethoscope, we hear no breath sounds or very diminished breath sounds in that one area. That's a tip-off that we're not expanding those alveoli properly in that area of the lung. We look for other areas of infection as well. Ears in children are very commonly infected, but usually with pneumonia you have more of a respiratory problem that's more isolated. And the diagnostic test is simple. It's a chest x-ray. You can see here on the x-ray, I think right there, the lower lobe there on the right side is what we call consolidated. It means there's fluid in that aspect, that area of the lungs, and that indicates a pneumonia going on. usually a bacterial pneumonia when you have a picture like this. Blood tests are useful for evaluating for pneumonia. So for example, with a bacterial pneumonia, you'll have an elevated white blood count oftentimes when you get a CBC, complete blood count. With a viral pneumonia, typically you have elevated lymphocytes, okay, a certain type of cells in the bloodstream that fight viral infections particularly. So we can get some idea as to whether we're talking about a bacterial infection or a viral infection. The treatment of pneumonia is pretty straightforward, assuming it hasn't progressed to the point where the child is so extreme that they have to be given oxygen and admitted to the hospital. Oftentimes this is done as an outpatient rather than an inpatient if the child is otherwise healthy enough. Antibiotics, as I mentioned, for bacterial infections. Viral infections, we give supportive care typically. Oftentimes these kids will get over that without too much of a problem. But I stress, it's assuming you have a normal immune system working properly and that you can have enough cortisol production to fight these infections because this is a major stress to the body. Stress doses of adrenal hormones, hydrocortisone, are typically given when you do have a situation where someone is identified already to have adrenal insufficiency and they're on hydrocortisone routinely. That's to help them fight any of these kind of stressful conditions like this pneumonia. Immunizations do prevent infectious disease risks. So we have the ability to control our risk of these kinds of serious infections in our kids with SLOS. These immunizations do save lives. There's no question about that. That data is really rock solid. And the complications of immunizations, although there are some, are usually far overblown. The major concern that you hear about in the news is, immunizations, this is causing autism in my child. Well, we have children with SLOS who already have autistic features, and you want to know, is this going to make it worse? I don't think it's going to make it worse. I think the protective nature of these immunizations far exceed the potential complications. And there is no association that's been proven by a number of medical studies looking for the effects of the incidence of autism in kids who have or have not had immunizations, and there's nothing there to be concerned about. Influenza particularly is an immunization that is not as effective as most of the others that we give our kids, but it is important because it does have some effect in preventing influenza. You have to give the immunizations on a yearly basis because the virus mutates from year to year. So you see here a little virus picture, diagram. You see the blue area? Well, the red area has mutated and the protein has changed a little bit from one year to the next. So we have to have a different vaccine that recognizes the new area that has mutated, and that's used, therefore, on a yearly basis. The major concern with flu vaccines is that in order to be able to have an effective vaccine that can be given to millions of people around the United States and elsewhere, you have to know what that mutation is. So there's ways to predict that, but the prediction is not always correct. It's not always the best. And so from year to year, you will find, you'll read in the papers, last year the influenza vaccine was not so effective compared to the previous year. And this is kind of a game of chance here as to whether or not the vaccine will be the right one that's produced. What we do know, if you look at the numbers, flu vaccines have decreased deaths by about 50% or so. And therefore, it really is important for all of us to have our kids, and I say ourselves too, but anyone who is exposed or potentially exposed to a flu virus, to be immunized every year. Even if the vaccine is not so effective in preventing the disease, it usually leads to a milder course of the disease. So that's an important point equally as well as preventing it. If you have a child who's already got a chronic disease and has the potential for having complications from influenza or other viral infections, if you can prevent that complication or mitigate it so it's not so severe, that's the way to go, frankly. I throw out this now. Hypothyroidism has been reported in 1 or 2 or 3, maybe there are more patients with SLOS. It is not as common, I think, as adrenal insufficiency would be, but nevertheless, it's something that's easy to diagnose and easy to treat. So I throw it out as a risk factor, but something that we should be aware of. So what is the thyroid gland? It's right here by our neck. You can almost touch it, right? You can feel your neck here, right? You don't feel anything, though, because most of the time the thyroid gland is relatively small, but it's also soft and pliable. So I can't really feel my thyroid gland very much here, but it's there. And it's important because it makes thyroid hormone. Thyroid hormone is really used by almost all tissues in the body to support a variety of functions. It's really a major, like cortisol, a major hormone that affects all tissues of the body. And it's made in this process shown here on the upper right. The brain has an area called the hypothalamus and the pituitary that produces the hormone called thyroid stimulating hormone, TSH. That goes to the thyroid gland, and that stimulates the production of thyroid hormone, okay? We call them T3, T4, but that's not important. The thyroid hormone does its trick in our body. It does everything good that we need to do. As we make thyroid hormone through the gland, it feedbacks to the hypothalamus, and the brain essentially controls the need to push the thyroid gland to make more hormone or less hormone based on its needs. So in other words, it measures the amount of thyroid hormone in our bloodstream and tells our brain and tells our thyroid gland to make more or less of it, okay? So if you have hypothyroid, what symptoms do we see? Well, these are listed up here. In younger children, fatigue, lethargy, growth failure are common features, right? Developmental delay can be seen. Constipation is very common in these kids. Some of them have thick skin. Some have coarse facial features. If this hypothyroidism has its origin in infancy and goes along for a year or two, you'll see the changes in the facial appearance of the children. In older children or adults, we have fatigue, exercise intolerance, weight gain. You know, you always hear about weight gain. Check my thyroid hormone levels, right? Cold intolerance is something as well. Hoarse voice, slow speech, droopy eyelids. These are all features that are very subtle, and that's an important point. These are things that you don't see if you're living with a child every day. You just don't notice it. It's amazing how many parents come in with a child who has some physical features or symptoms of hypothyroidism who don't even notice it, but others can see it. How do we diagnose it? It's easy. We measure a level of TSH in the blood and free T4. And if the TSH is high and the T4 is very low, then we can diagnose hypothyroidism pretty effectively. Treatment consists simply of giving them thyroid hormone, okay? And when you do that, you can reverse the features and the symptoms that they have, and that's the great thing about it. But you got to get the diagnosis made fairly early on. You can't let someone go for years hypothyroid and expect things to just reverse like that overnight. It's not going to happen. That's why we want to be vigilant about this and make sure that our children don't develop this. This is a low-risk kind of complication in SLOS, but I think we don't really know the actual risk that these kids have because we don't have the data. Okay, in conclusion, what can I say? Well, serious and sometimes life-threatening complications occur in this disease. That's clear enough. That's very clear from what we just heard. Some of these complications are easily diagnosed and treated or prevented using various approaches. And emphasize this, I can't emphasize it more and more. More research is needed to define the true incidence of these serious complications and risks, to understand things like immune function and lack of that if there's there, and determine if cholesterol supplementation may be beneficial or other medications may be beneficial to prevent these complications. It seems to me that, we've been talking about cholesterol supplementation and whether or not it's beneficial. It may or may not be beneficial to the nervous system and brain of these kids because cholesterol doesn't get into the brain. But cholesterol levels are important to have as high as we can get them, within the normal range, of course, as high as we can get them because that cholesterol is used to make some of these other hormones within the body. And we need to be very aware of that. So I would be happy to take any questions at this point in time, knowing that I don't have a lot of answers. Okay. Yeah.
So we have a son who's 18, and he's had these 2 unusual episodes where he sort of got collapsed, and he ended up in the emergency room, and we took him down there, and they hydrated him, and then they sent us home. But after looking through your diagrams, I'm almost 100% sure that he is both adrenal insufficient, and I'm pretty sure that he's probably hypothyroid as well. I have an appointment with a metabolic specialist at CHOP in like a week and a half, so I'm going to bring up these subjects. What would be really helpful, because when we've gone to the emergency room and we've sort of mentioned some things, I guess because it's not documented or there's not enough literature out there amongst the community of physicians about SLOS. Even when he's had crises, I said, I'm pretty sure that they made the recommendation he was supposed to have FFP or steroids to help him, but it just doesn't seem to, for me to tell a doctor to do that, it just doesn't come across.
I think you just need to let the doctor know if they don't already know it. And the metabolic docs probably know this.
Mm-hmm.
And
well,
probably,
this is the first time I'm going to a metabolic doctor.
Okay, so you're going to go to someone probably who has a lot more experience than the other doctors you've been to.
Yeah.
But we know the adrenal gland depends on cholesterol greatly to make cortisol. And adrenal insufficiency would be one of the major red flags that I would think about in any child with this disease, whether they have symptoms or not. Mm-hmm. Now, adrenal insufficiency is something that happens usually slowly over time, mm-hmm. and you can measure the cortisol levels maybe once a year is sufficient, mm-hmm. because you're going to get an indication that the adrenal gland is going to be failing because the ACTH level will slowly rise, even though the cortisol may be fine. If they just measure the cortisol level, they'll miss the fact that there's insufficiency in the adrenal gland. It's not working as well. It has to be stimulated even more and more by more ACTH, mm-hmm. and that can give a clue. So I always suggest and recommend that you get both of those measurements, ACTH and cortisol, and get the cortisol in the morning. It doesn't have to be a fasting sample, but it should be done in the morning because of that variation you see.
And it's comical because we always say he's constantly wanting to eat chips, so he's probably like self-regulating, trying to pull up his salt. He
might need sodium. That's it's a possibility, certainly. And that may be a clue that someone's having adrenal insufficiency. They're craving for salt. Yeah. Yes. You give them hydrocortisone. The question is, if they do have adrenal problems, how do you treat that? Well, it's easy to treat it. You just give them hydrocortisone. That's basically converted to cortisol, and it does the same thing that the body's own cortisol will do. Yeah. I might add that adrenal insufficiency is a difficult diagnosis if you're not suspecting it. If it's not in the back of the doctor's mind that this kid might have adrenal insufficiency. We've seen many kids who have been missed because it hasn't been so severe that their sodium was 120, let's say. It can be subtle. Yeah.
kind of blood issue that has gone undetected for 28 years. That underlying part of his cause is a blood issue. He kept asking us, because he looked over his chart and stuff, and he says, does he have blood issues? And I'm like, no one has ever told us that.
I want to mention something. You know, when we have these kind of stress episodes, our kids can have a normal cortisol, right, during times when they're not stressed. But when they're stressed and they need to make more cortisol, they can't make it because it's not functional. They don't have the reserve, the adrenal gland reserve, to be able to make more cortisol. That's why it's important to get both of those measurements, cortisol and ACTH, and not just rely on ACTH levels alone, because you'll miss it.
The only thing that they told us was he had no albumin in his blood.
That was low.
His level was between 2 and 3 and should have been about 7, if I'm correct. So they said they would give it to him on a trial for a weekend, and they ended up keeping it on him, giving him the blood product for 21 days. And then they finally just put him in hospice.
Yeah.
And then he got better.
Yeah.
So was that just his body kicking back in? Because no one could ever explain why he got better.
Usually when you see low albumin, you think the liver isn't making the albumin sufficiently, so you kind of focus in on the liver function. But sometimes it's not that alone. There's other causes for low albumin as well. I can't tell you about your particular situation. I just don't know enough about it. But I throw out, these are some of the particular risks. There are others, too, that we haven't talked about. But we don't know what the particular risks are in most cases because we don't have the data. That's why these registries and these natural history studies are so important for us to follow. Any other questions? Yeah.
Actually, two. The first being, is there any recommendation for how often you check those levels? The adrenal level and the cortisol level, if I'm saying those right? The two levels that we should have checked?
Yeah.
I mean, like, is it?
You don't have to do it monthly or even every 6 months typically.
Every 5 years, every 10
I
years?
think every year or two is probably sufficient, but we're talking about an older child.
Right.
A young baby, a severely affected baby with a low cholesterol level should be checked right away, and then maybe more frequently afterwards.
Well,
if you can't get the cholesterol high.
We've kind of hit our average. We run within the past few years that we've had it checked. It's within, 3-4 numbers of each other. Pretty much, we're consistent, is what I would say.
Yeah.
So maybe we're at that point, and depending on how much growth we have, I don't know if that would affect it or not.
So there's no consensus as to how frequently to check cortisol levels. I don't think that if we talked among ourselves on the medical advisory board, we would come to a general agreement perhaps, but not a absolute agreement because there's so much variation in SLOS. Levels of cholesterol vary tremendously among patients. Probably the levels of cortisol, if there is deficiency in a patient, it's going to vary a lot too. So I don't have any direct specific number to give you, but just be aware that that might be a serious risk.
Okay.
Yeah.
My second question, or statement rather, is we are on cholesterol suspension with the cherry solution, and I notice significantly changes in behavior. However, I know that it doesn't cross the brain barrier, but what you said made me think, well, if it's contributing to how he may physically feel, then that could affect behaviors. Because if you feel bad, then you're going to probably not act as well.
It's perfectly conceivable that that's the case. I don't know.
Right.
Yeah.
Thank you.
Yeah.
Just a general question. I'm just kind of interested, knowing that there's a lot of people out there, kids out there, not getting diagnosed. I'm interested from your standpoint, how is a child diagnosed? I mean, you function or you work out of Omaha. Are you a resource center to other pediatricians that have an inkling that there might be something going on with this child? I mean, in practicality, how does it work that a child gets diagnosed with SLO? The other thing is, and this is kind of a quirky thing, I mean, being in the role that you do, you must walk through an airport or a mall and see different people and think, I mean, there's been numerous times where Gretchen and I have been at a restaurant and, you know, you will say, well, look who looks like. Yeah, if you could just, I mean, it's a general thing, but it's very interesting, and knowing full well that there's a lot of people out there that aren't getting diagnosed.
I agree. And your question is a very general question. There's no one answer. So we've had kids who have been diagnosed in the NICU because they had the features, the physical features, the webbed toes, for example, that we see in SLOS. They were tested, and therefore the diagnosis came about that way. I've seen a 54-year-old woman who was referred to me from an institution in Nebraska who came into the clinic one day. They asked me to see if there was a metabolic disease causing the intellectual problems with this woman. And she was in a wheelchair. I examined her. I got history as best as I could. I examined her. And then since she was in a wheelchair, I didn't really get her out of the wheelchair to examine because it wasn't convenient, right? But before I left, and I ordered up all these tests, and before I had her leave, I said, let's take her shoes off and check her reflexes, right? Lo and behold, she had the 2-3 syndactyly toe, and that came to the diagnosis that way, 54 years of age. So it's subtle, you know, and her cholesterol level was actually normal, but the 7-DHC was high, and the diagnosis was therefore made because of that and the features. So there's a lot of ways to get to the diagnosis. The problem is most doctors don't know about this disease, so they don't think of it. So they don't tie it all together. Sometimes, with developmental delay or some physical features, they're seen by a geneticist. I think the geneticist is aware of SLOS pretty well. So they make the diagnosis, or they do the testing to suspect the diagnosis. They go ahead and do the testing, and it comes back positive that way. So there's a whole wide range of people getting to that diagnosis. We don't do newborn screening for SLOS, right? Theoretically, that should be possible, but that's a whole other question, issue that we need to deal about. But that would be a way to kind of get to the diagnosis quicker. And in a wider range, we'd see the variation that we would see otherwise. I'm not sure whether that is feasible. I think from a theoretical point of view, it should be, but I just don't know. Yeah. Any other last questions? If not, you can certainly ask me anytime. Thank you.